Hello, welcome to the Introduction to Parenting at Mealtime and Playtime. My name is Sarah Adams, and I am the Medical Director of the PMP program through the Ohio chapter of the American Academy of Pediatrics. Today we're going to talk about the top things pediatricians need to know about nutrition. And what I want to mention to everyone today is that today most of what we are going to be talking about is going to be a nice review, and also we are going to clarify some of the new recommendations and provide some new ideas for you to talk about with your families when they come in your well office visits. All of the information is provided to help you get started in our mission to reduce the risk of childhood obesity. So we're going to give an overview of nutrition, talk about introducing solids, beverage consumption, some ideas on how to help parents understand fullness cues, discuss the new recommendation to introducing solids and how to reduce food allergies, and then just a few comments on playtime and screen time. So let's talk about caloric needs. In infancy, as you can see, in the early months, their caloric needs per kilogram weight is much greater than their needs as they get older. And this is a good review because we realize that as they get older, they tend to get pickier, and parents become more anxious about what they're consuming. So, in the beginning, it's easy. They're breastfeeding, they're taking in formula, but when do we know when they're ready for solids? And this is a common question that I get in my practice. The PMP program has a wonderful handout that you can see on the right-hand side of this screen that gives us a really easy way for parents to take home and have a chance to read. But very simply, what we know is that if they've got adequate truncal control, which means that they can push up from the prone position with straight elbows, if they have the ability to propel pureed food to the posterior pharynx when they're swallowing, and if they have gotten rid of the excrusion reflex, which happens about between 4 and 5 months, then we know that they're ready for solids. But this handout is nice in a quick, easy way during your busy wellness visit to give them to take home to read or review if you have time during that busy office visit. So preparing them for solid foods really comes from the baby's cues themselves. So I often tell the families, look, here's how we know. Are they putting their hands in their mouth? Are they bringing toys to their mouth or different objects and mouthing them? That tells us that they're probably ready. And we know, okay, are they desiring? Do they have a desire for food? Are they opening their mouth and leaning forward, especially during mealtime when you're eating? And then just the opposite. Do they look like they're full by leaning back and turning away? Really simple things for parents to learn and understand. And again, on the right side of the screen, these are some easy, quick cues to be able to say, this is how you know your baby is ready. There are, though, some harms and risks that we should go over if the parents, try to feed their baby too early or they wait too long. There's aspiration. There's inadequate or excess intake of energy or nutrients and increased renal solute load. There's increased risk of obesity in some studies. Initiation of solid foods can lead to some potential harm or risks. These can be aspiration, inadequate or excess intake of energy or nutrients, or increased renal solute load, increased risk of obesity in some studies, feeding cereal to infants at high risk for type 1 diabetes before 3 months may increase the risk of development of islet cell antibodies, and celiac, which is a completely other discussion. Other potential risks include decreased growth because of inadequate energy intake, iron deficiency in breastfed infants if iron supplementation is not provided as recommended, delayed oral motor functioning, aversion to solid foods, development of atopic diseases such as asthma, allergies, eczema, and food allergies. The introduction of solid foods to infants at high risk of developing allergic disease is also a risk. And again, as I mentioned, type 1 diabetes, delaying the introduction of cereals to infants at high risk until after 7 months can also increase the risk of development of islet cell antibodies. Complementary foods, sometimes known as weaning foods, solid foods and liquids other than human milk or infant formula that are eaten by infants as they make the transition from a liquid diet to a modified adult diet. And there's also been studies to show that breastfed babies who waited until 6 months to start these complementary foods had the same growth but less gastrointestinal infections. Baby-led weaning in the first year. The first time I heard this, I thought to myself, well, this is kind of an odd way to put it. And it worried me that parents were going to stop breastfeeding or stop giving formula before 12 months. But really what this is talking about is introducing the complementary foods so that by the time they are 12 months old, then they have transitioned from the breast milk or formula to these complementary foods. So I almost wish that they would call it baby-led feeding. By the end of the first year, most healthy infants obtain one half of their energy needs from these complementary foods. By 6 months, these foods become necessary to support their growth, satisfy their hunger, and supplement energy and nutritional needs. And after 6 months, the volume of human milk ingested by exclusively breastfed infants generally becomes insufficient to meet the infant's requirements for energy, protein, iron, zinc, and some of the fat-soluble vitamins, such as vitamin D. So what are we going to feed them? Single food ingredients first. The AAP Committee on Nutrition suggests infant cereals and pureed meats be offered first because of their content of iron and zinc. Strained or pureed fruits and vegetables, at least 1 feeding per day should contain foods rich in vitamin C to promote iron absorption. Fat and cholesterol intake are not restricted in infants, and no added sugars or salts. But what about cereal? Well, infant cereal should be prepared with breast milk, formula, or water, fed with a spoon, not in the bottle unless medically indicated, and this helps with oral motor function and speech development. Adding cereal to the bottle may contribute to the development of obesity due to the calories and also confuse the baby's signals to satiety and their thirst. Infants, though, with gastroesophageal reflux who are managed with added cereal in the bottle should also receive cereal with a spoon when they are developmentally ready for solid foods. This is a nice handout that I have. You can copy it as well and provide it for your families. What I do tell parents, though, is I say that the child did not read the handout. In other words, they might eat or drink a little bit more than what's on the handout or a little bit less. So it's purely just a guide. A lot of times parents just want to know exactly what to do. It's also a nice way, as a visual way, to teach them exactly what they need to know. Repeated exposure and variety. So by 8 to 12 months of age, they should be encouraged to offer fruits and vegetables at least once a day and offer a variety. And very often, they're going to refuse different kinds of fruits and vegetables. So if they refuse it at one meal or one day, offer it again at another day, another meal. But variety is the key, and repeated exposure is the key. Even up to 15 times might be necessary before a new food is accepted. And this is an important thing to provide for our families and our parents. Breastfeeding may facilitate the acceptance of these solid foods as a result of the variety of flavors that are transmitted through human milk. I would like to take a moment to talk a little bit about home-prepared pureed food. Parents may choose to prepare pureed food at home for a variety of reasons. It's fresh. It has a variety of textures. It improves costs and avoidance of preservatives. But it's important that when you are guiding them, that they ensure that the energy and nutrient content is adequate, that their home prepared foods have the same variables as the foods that are prepared commercially. Infants younger than 4 months of age should never be given home prepared spinach, beets, green beans, squash, or carrots, as these foods may contain sufficient nitrates to cause methemoglobinemia. We also have to take sodium into consideration. Read labels for sodium content and buy no added salt products. Canned foods should not be used to prepare pureed infant foods, as they do contain large amounts of salt as well as sugar. Dietary reference intake includes sodium of 120 milligrams per day for infants 0 to 6 months and 370 milligrams a day for infants 7 to 12 months of age. Finger foods. Let's get messy. By 8 to 10 months of age, infants begin to refine the skills necessary to eat finger foods independently. They have the ability to sit independently, the eye-hand coordination needed to grasp, manipulate, and release food, and the ability to chew, even in the absence of teeth, and of course, swallow. By the time they're 12 months old, the hand grasp matures to a fine pincer grasp, improving the ability to eat finger foods. Finely chopped soft foods such as pieces of soft fruit, vegetables, cheese, well-cooked meats, pastas, and foods that dissolve easy, such as baby crackers, dry cereals, can be offered as finger foods. Foods that are choking hazards should be avoided, including hot dogs, nuts, particularly peanuts, grapes, raisins, raw carrots, popcorn, and round candies, but I know you all know that. By 9 to 12 months, most infants have the manual dexterity to feed themselves, drink from a standard cup with 2 hands, and eat prepared foods for the rest of the family with minor adaptations, such as cutting it into bite-sized portions appropriate for them. Now, obviously, every child is developmentally different, so we want a healthy feeding relationship. So the infant initiates and guides the feeding interaction. So the caregiver must respond early and appropriately to the hunger as well as the fullness cues. They must recognize the infant's developmental abilities and the feeding skills. And they must balance the infant's need for help with encouragement of the self-feeding. I always use my own children's examples. When my oldest son was going to have his very first time at pureed foods, I had the video ready, I was ready, it was so exciting. Developmentally seemed appropriate. We were so excited, and we started. By the end of it, he was crying, I was crying. He just wasn't ready. Later, he was a champion at eating. Then came child number 2. He loved to eat, but he was a choker. He gagged on everything. So solids and textures were a little bit more difficult for him. So the key in regards to educating our parents, once again, is that the infant initiates and guides the feeding interaction. And we really need to remind our caregiver that it is that we have to respond appropriately, and that it is very important that we create a positive relationship to these healthy feeding habits. I'm going to switch gears and talk a little bit about our nutrition, and then we're going to discuss a little bit more about beverage consumption. So, minerals and vitamin supplementation. I get this question a lot. Iron. So, in a full-term infant, they need at least 1 milligram per kilogram. Premature and low birth weight, 2 to 4 milligrams per kilogram. Breastfed, 7 to 12 months, 11 milligrams per day. Cereal with breast milk, complementary foods, iron supplements are how they can gain this. Formula fed, 12 milligrams of elemental iron are per liter, so they are of formula, so they do not need any additional supplementation. So as you can see, the minimum daily requirement for iron varies depending upon their age, gestational age, birth weight, as noted. Fluoride. Remember, every baby with teeth needs fluoride. So it is important to ask the question, do they have teeth? Beyond 6 months of age, of course, before 6 months is another question. And do they have city or well water? Vitamin D. Are they exclusively breastfeeding or not from birth on? And then vitamin B12 needs to be a discussion because it is important to have adequate intake of vitamin B12. And the reason why I mention this is mostly because if you have an exclusively breastfed baby of a mother who is a vegan, for example, you might want to recommend that she is either eating a diet that's rich in vitamin B12 or make sure that she is being supplemented. And then as the children become older and they are eating the complementary foods, as noted, then you want to make sure that they are also eating foods that are rich in vitamin B12, if indeed the mother is also providing a vegan diet to her children. And then the fat-soluble vitamins, we want to make sure that if there's a history of cholestasis or history of fat malabsorption, we need to take those vitamins into consideration as well. Nutrition for toddlers, preschool, and school age. Key issues here. When they're toddlers and preschool, you can make sure they're transitioned to a cup by now, using their utensils, absolutely feeding themselves. There is a huge fluctuation in appetite. Make sure that they're achieving adequate iron and zinc intake through their diet. Avoid overconsumption of juice and sweetened beverages. Before we get into beverage consumption, I did want to mention some key issues about nutrition for toddlers, preschool, and school-age children. For toddlers and preschoolers, they should by now be transitioned to a cup and feeding themselves with utensils. There is a large fluctuation in appetite. We really want to ensure that they're achieving adequate iron and zinc intake. avoiding overconsumption of juice and sweetened beverages, and that they have developed routines for healthy eating and activity. By the time they're in school, we really want to make sure that they are taking in an adequate amount of fruits, vegetables, calcium, vitamin D, and fiber. Avoidance of energy-rich, nutrient-poor snacks, such as salty snacks, cookies, sweetened beverages, overconsumption of sugary, sweetened foods and beverages, and we want to encourage them to have a development of a healthy body image. So by doing that, we really want to set the stage for good feeding behaviors. By doing that, we want to encourage our families to look at their development, to help each child based on their temperament, talk to them about their personal experiences, and realize that each of them may have different medical needs. Their environment plays a huge role in what their feeding behaviors may be, their family dynamics, their ethnic dietary practices, and of course, their food accessibility. Do they play with their food? Do they enjoy their mealtime? As another way to look at it. We all know that the toddler age, we expect food jags. Do they offer new foods several times? Or just give up and say they're just a picky eater? We need to be more aware of what their feeding environment is and what their dynamics are and their ethnic practices, and their food accessibility, as I mentioned, so that we can help them. We want to help them create that family mealtime, model healthy eating behavior, help them make good choices, because that is what is going to set the stage for the child. By the time they're school age, ways that we can encourage them to help is say, well, why don't you talk about what you like to eat? Maybe help with meal planning, help prepare the food, help clean up. Maybe you would like to talk about what snacks you like to do, or even go shopping with mom or dad. These positive influences at home can affect their food choices and actually can help them affect their food choices when they're away from home. Their nutritional needs, as we've already spoken about in this presentation, depend on their age and their level of activity. I really like the Choose My Plate, and this is something that the PMP has a lot of resources around. And there's also an interactive website that provides individual dietary guidance. You can encourage your families to look into it, and it talks about the energy from protein, from fats, from carbohydrates, and what the children gain from that, and how much total energy intake that they get and what they need at different ages and depending on their different sex and level of activity. As always, sugars should be avoided. This is much like the dietary recommendations that I showed you for infants. This one is for toddlers and early school age children. Again, I always say to parents, especially the toddlers, they're not going to eat all this in one day. They may not even eat it in 2 days. Sometimes you have to look at what they're eating over a 2 to 3 day period, and that's okay. I say they didn't read the paper. It's just merely a guide, and every child is different. If you note, though, for more details, it does say go to www.choosemyplate.gov. This is another handout that talks about dietary guidelines for children older than 1, really going into a variety of nutrient-dense foods from a variety of basic food groups that should be offered each day. Again, fat and cholesterol should not be restricted, and it goes into more and more detail about how many cups a day of milk, etc. Because these are the questions our parents ask us every day. So, in a nutshell, their diet should be well balanced, variety of nutritious, developmentally appropriate foods with a recommended number of servings of nutrient-dense foods from basic food groups offered every day. Examples are animal products, full complement of amino acids, alternate sources from plants, sometimes don't carry the full complement of amino acids, so there needs to be some dietary planning. I'm not saying that you shouldn't encourage them to only eat animal products. Actually, when I tell my families, when it comes to protein, I say limit what you eat that has 4 legs. I say then the next is 2 legs with skin. And then I tell them that the healthiest is protein with no legs. But you do need to plan and make sure that they are getting the full complement of amino acids. The AHA recommends 2 servings of fish a week. Fruits and vegetables, let it be hands-on. It's way more fun if maybe they've gardened it themselves, but certainly cooking. Selection, like I said, either help them, encourage them to make the shopping list themselves or prepare the food. Cut it into shapes and dips. Make it a variety, different colors. Eat the rainbow. Role model, parents. I always tell parents, if you're eating it, there's a good chance they'll eat it too. Make them accessible. I learned with my family, if I took out the apple and cut it, it was gone. If I let the apples sit in the fridge, nobody touched them. Add the fruits and vegetables to sandwiches, pastas, chilies, soups, casseroles, pizza, cereals, and pancakes. Provide them as snacks, repeated exposures, and explain to the kids what it does to their body and how good it is. At least 1/2 of their total grains should be whole grains, and give them some examples of what that can be. Whole or cracked wheat, crackers, oats, oatmeals, rye, barley, corn, brown or wild rice, and quinoa. They're an excellent source of fiber, plus several vitamin types of B vitamins, iron, magnesium, and selenium. And it's the optimal intake of dietary fiber for infants and children younger than 2 is really not known, but for children older than 2 is 5 to 10 grams a day. And then just keeping in mind that vegetables or a piece of fruit provide quite a bit of fiber. Now, I don't always give my families the numbers because I don't want them to go crazy. I just try to talk in terms of servings. Dairy. Children 12, now this is after 12 months of age, should be drinking whole unflavored cow's milk unless they have a cow allergy or cow's milk allergy or intolerance. And of course, some are still breastfeeding, which is wonderful. Children between 12 and 24 months of age should consume at least 2 8-ounce cups per day and eat foods rich in calcium to meet their daily calcium requirements of 700 milligrams a day. over 24 months, children over 2 years should consume fat-free or low-fat cow's milk, 1 to 2%. In addition, calcium and vitamin, they could also be doing calcium and vitamin D fortified soy milk or equivalent cow milk or fortified soy milk products such as yogurt or cheese. And between 2 and 8 years, consuming at least 2 to 3 cups per day and eat foods rich in calcium to meet their daily calcium requirements, as noted in there. Again, a lot of times I don't give them the milligrams because I don't want them to count milligrams. I do, however, have a really nice calcium handout that I provide for families that also has non-dairy forms of calcium in case they do have certain milk allergies and intolerances that is important for them. If you have to substitute yogurt for cow milk, they should review the nutritional label to make sure it contains an equivalent amount of calcium and vitamin D without too much sugar added. So what about plant-based milks? It is not recommended for children under 5 years of age unless they have a cow's milk allergy or intolerance. These examples include soy, almond, rice, coconut, and hemp milks. Some newer alternatives are quinoa, oat, potato, and mixed grain. Soy milk has the nutritional profile that is most similar to cow milk and is usually fortified with calcium and vitamin D. Others are lower in protein, calcium, vitamin D, and calories, and certain vitamins, minerals, and fatty acids, although they are improving. And so reading the label is important. Children may require multivitamins or vitamin D supplementation. Consider a nutritional consult if an allergy or there is an other personal or ethnic concern. Other beverage consumption, soft drinks and sweetened beverages. We really want to discourage consumption. So don't be afraid to ask if they are drinking soft drinks. It is a major source of sugar in their diet, a major contributor of the development of obesity, and it has a low intake of key nutrients. So I tell my families, look, it has no nutritional value. It's going to cause obesity, and it's full of sugar. But don't encourage them to have low-calorie sweetened beverages. And this includes saccharin, aspartame, sucralose, and even stevia. There's no benefits over plain water. Adverse effects are still being researched, and it causes a decrease in the intake of healthier beverages, and they can still develop a preference for sweetened beverages, and it alters their fullness and hunger cues. Caffeinated beverages are not recommended, and there's very little information on short or long-term effects. Frequency of meals and snacks, especially when it comes to our toddlers. So they can eat 4 to 6 times in a day. So we would think, okay, 3 meals a day plus snacks. Snacks are an essential component of a young child's diet. Toddlers eat an average of 7 times a day. Preschoolers tend to eat 3 times a day and smaller snacks. Remember that portion sizes are small, and we want to encourage that because we don't want to have large portion sizes of snacks, because that's going to contribute to overeating. Vitamins and supplements are not necessary for a healthy child who is eating a varied diet. So remember, we've talked about what to eat. We've talked about vitamins. We've talked about behavior. It's so important to remember to not overfeed. So we need to know what these signs of fullness are And when it comes to infants, it's about sounds and movements because they can't talk, right? So from 6 to 12 months, they might close their mouth, turn away from the breast or the bottle, or just relax their hands. They could push food away if they're at the point where they're eating, close their mouth. When the food's being offered, turn their head away from the food, or use hand motions or make sounds to let you know that he or she is full. They don't need to finish the bottle or all the food in their jar or even on the plate. Responsive feeding is so important. We need to teach parents to watch for the baby's cues, to respond warmly and promptly, feeding the right foods for their age, stopping when they're full, focusing on being affectionate and nurturing for meal times is so important. And what does this mean? So starting and stopping the feeding often. If they're spitting out or ignoring the bottle or breast, if they're unlatching while they're breastfeeding, if they're closing their mouth or turning their head away, if they're fidgeting or getting easily distracted, or they slow down or fall asleep, they are responding, and parents need to understand what that means. And if they do, and they understand and they respond warmly and promptly and affectionately, like I mentioned, they will have infants and babies and toddlers that will develop healthy eating habits, know when they're hungry and when they're full. They'll develop stronger bonds, and they'll learn that mealtime can be fun. When it comes to toddlers, they'll turn their head or shake, their head no, or they might even say no more, all done. They'll throw their food, and that could mean that mealtime's over and it's playtime now. They'll cover their mouth. They'll cover their face with their hands. They'll cross their arms. They'll refuse food. Their chewing might slow down. Their attention could be off. They might even spit their food out. They'll lose interest. They'll lock their lips, squirm, or throw things or push their things away with their hands. So forcing them to have a clean plate equals difficulty at mealtimes, resentment, and power struggles around food. If we pressure them, it only leads to negative long-term effects, overeating, and learning to be unable to recognize when they're full. Beverage consumption is something that is so important, and I think that we are lacking in really questioning. What are they drinking and how much? We need to know exactly how much are they drinking outside of the breast milk, the formula, especially under 12 months of age. No juice under 12 months of age. Over 12 months of age and up to 3 years, only 100% fruit juice and no more than 4 ounces a day in a cup and not in a bottle. But still, I would recommend no juice even in that situation. But if they really feel like they're going to give them juice, then no more than 4 ounces. Juice reduces appetite for nutritious foods and solids, causes diaper rash, diarrhea, and excess weight gain and tooth decay. Healthy babies do not need water. Breast milk and formula have all the fluids that they need. Water can be introduced with a cup when introducing small solids, very small amounts. It can also be given in small amounts when it's hot weather, or to provide a small amount of fluoride when they have teeth during brushing. The AAP Committee on Nutrition has this recommendation about beverages to avoid in the first year of life. Cow's milk avoided before infants are 1 year of age because of increased renal solute load and the risk of iron deficiency. Plant-based milk does not meet the nutritional needs. Fruit juice, not even 100%. It's overnutrition, undernutrition, diarrhea, flatulence, abdominal distension, and dental caries. Sugar-sweetened drinks, increased risk of obesity and dental caries. We're going to shift gears now to talk about food allergies and sensitivities. This is a very important topic and a lot of the new recommendations that have come out. So late introduction of solid foods may actually increase the risk of allergic sensitization to food and inhalant allergens. In a study with children susceptible to type 1 diabetes, late introduction of solid foods was associated with an increased allergic sensitization to food and inhalant allergens. Eggs, wheat, oats were most commonly related to food sensitization, while potatoes and fish were strongly associated with inhalant sensitization. The American Academy of Pediatrics recommends the introduction of solid foods between the ages of 4 and 6 months. Study authors concluded that neither extended exclusive breastfeeding nor delaying the introduction of solid foods prevents allergic diseases in children, which is what we used to think. For many years, as I mentioned, experts recommended delaying these allergic foods until 12 months as a way to prevent, especially eczema. But we know now that this is no longer true. Recent guidelines show that there's no benefit in delaying this introduction, and a study in 2015 actually showed the importance of early introduction as a means of prevention, as means to prevent allergy in high-risk infants, meaning infants who had severe eczema and or an egg allergy. So what do we tell the parents? It gets a little confusing. So I'm going to spell it out in a couple different ways. So we're going to start with solids, with a few foods that are what we consider low allergy risks. One new food at a time for 2 to 3 days, and watch for vomiting, diarrhea, and rash. If an infant has no high risk for food allergies, and if the first foods were tolerated, then you can introduce more highly allergenic foods such as dairy, egg, soy, wheat, peanut, tree nuts, fish, and shellfish. Again, one at a time for 2 to 3 days before introducing a new form. Remember that the form and the texture should be appropriate for the infant's age. It's for parents. So I'm going to go over this a couple different ways because it does get confusing. So for a child who is low risk for developing, wait a minute, hold on a second. Let me start. Advice for parents. I'm going to go over this in a couple different ways because it gets confusing. For a child who is at low risk for food allergies, you're going to start solids with a few foods that have a low allergy risk. One new food at a time, over 2 to 3 days, watching for signs of intolerance or allergies such as vomiting, diarrhea, and rash. If the infant has no high risk for food allergies, as I mentioned, and the first foods were tolerated, then you can introduce more highly allergenic foods, again, one at a time: dairy, egg, soy, wheat, peanut, tree nuts, fish, and shellfish, in forms and textures appropriate for the infant's age. No cow's milk, but they can have Greek yogurt with fruit they have tried already, for example. Babies with severe persistent eczema or an immediate allergic reaction to any food especially a highly allergenic food such as egg, he or she is considered high risk for peanut allergy. They should call you, stop giving the food, referral to allergy testing, or supervised setting introduction before trying peanut-containing products. Ideally, peanut-containing product should be introduced as early as 4 to 6 months of age. For a baby with severe persistent eczema, it is highly recommended to have an allergy evaluation before then. Babies with mild to moderate eczema are also at risk of developing peanut allergy. So waiting until 6 months of age after complementary foods are introduced, peanut-containing products can be introduced at home, or a referral to allergy evaluation can be made. Babies without eczema or other food allergies who are not at risk for developing an allergy may start having peanut-containing products and other highly allergenic foods freely after a few solid foods have already been introduced and tolerated without any signs of allergy. The highly allergenic foods should initially be given to your baby in small tastes at home, and the amount can gradually be increased in a developmentally appropriate manner if there are no signs of intolerance or allergic symptoms. Introduce peanuts in infancy by mixing and thinning out a small amount of peanut butter in cereal or yogurt. You could dissolve peanut butter puffs with breast milk or formula and feeding it by spoon, but remembering to always prevent choking. Even breast milk has a very small percentage of allergy or sensitivity. 2 to 3 out of 100 infants have an allergy to human breast milk. Usually, if there's a concern, very often it's actually the cow's milk protein that is in the breast milk. Symptoms that they may present with include inconsolable crying, abdominal discomfort, eczema, hives, vomiting, diarrhea, blood in the stool, or difficulty breathing. Food sensitivities often are presented with minor reactions when a mother eats certain spicy or gassy foods. The baby cries, fusses, nurses more often, but very often you do not see a rash, a change in breathing, or diarrhea. Breastfeeding in the first 6 months reduces the rate of food allergies and sensitivities. Altering mom's diet shows very little help in reducing the chance for development of asthma or allergies. Family history of severe food allergy, consider recommending limiting maternal intake of milk and dairy products, fish, eggs, peanut, and other nuts during pregnancy and while breastfeeding. Hydrolyzed formula can be helpful to reduce eczema in certain situations. So hopefully that has helped in regards to a nice review of nutrition, the food allergy guidelines, in introducing solid foods, in reviewing beverage consumption, in behaviors around meal times. Screen time has become an important topic in regards to our concern for childhood obesity. Among the AAP recommendations, we want to make sure that we are discussing screen time with our families. And remember that for children younger than 18 months of age, we want to avoid screen time and media other than video chatting. And if we are going to not let them introduce digital media. But if they are going to do it, they should be choosing high quality programming and watching it with their children to help them understand what they're seeing. For children 2 to 5, again, no more than 1 hour per day, high quality programs, co-viewing the media so that they understand what they're seeing and applying it to the world around them. For children age 6 and older, there should be consistent limits placed on the time spent using media, the types of media, and the media should never take the place of adequate sleep, physical activity, or other behaviors essential for health. There should be designated free media zones, as I call it in my home, such as the dinner table, when you're driving, media-free locations, such as their bedroom, and have ongoing communication about online citizenship, safety, and treating each other with respect online and offline. In addition, we don't want screen time to take away from their playtime, from their physical activity. And playtime starts even from the beginning. We need to remember that during their well visits, we want to talk about playtime at every developmental stage. But we have to take into consideration not only their developmental stage, but the family schedule. We want to talk about what their preference is for activity. We want to give them advice about structured physical activity, but also less structured physical activity, and have fun, but playtime with some purpose. Purpose meaning, purposefully doing things so that they are interacting, making eye contact, and learning together. These activities go from tummy time as an infant to encouraging them to play for 60 minutes or more of physical activity as they become a school-age child. Speaking of tummy time, there are so many ways to tell them how to do tummy time. You can tell them, instead of just saying, are you doing tummy time? Great, check. Talk about tummy time. Tell them they can do tummy to tummy. They can do lap time, where they basically have a chance to look around their environment, or laying them on a blanket and lay down with them, either on their belly or on their side, and tell parents that this allows them to get an idea of a new environment, different textures and different views. It's very important to discuss with them, and you'll see during your chart reviews in the PMP program, how much time are they spending in a restricted environment, whether it's in their seat, in a bouncy, in a swing, and versus how much time are you getting that baby out and playing with them on a blanket, in a seated position if they're developmentally old enough. Distract them with a toy. Spend time reading with them. Tummy time activity doesn't mean just being on a blanket on their tummy. Most babies don't like it because they're not interacting with them. But if you're face to face, if you're reading to them, if you're playing with them with a toy, or maybe laying them on their side and letting them get a chance to feel what different textures of a blanket are like, etc., I think that the infants will like it a lot more. Play with a purpose, like I mentioned. Make sure that they're involving the different senses. Have them have toys that they can explore with their hands. Or if they're not reaching for things, what does it feel like along their cheeks? There should be different textures, different sounds, light, shapes, and sizes. Talk to them, sing. Belly time with toys out of reach so that the developmentally appropriate kids have to kind of scooch or roll or, roll to their side or turn a little bit just to reach it. Play games as they get older. Run, climb, kick, throw, jump, balance. Stack blocks, stack cups, color, paint, pull string, push toys. print letters, draw card games, puzzles. We all have ideas to help our families, and it just takes a few seconds based on their developmental age and their well visit time to just remind them that it's okay to play, to forget about the dishes for a few minutes and just take time out to play. Our mission of the PMPQI program, the Parenting at Mealtime and Playtime Quality Improvement Program, is to achieve the best clinical care and healthy outcomes for children aged birth to 5 during these well visits. We want to use developmentally age appropriate and behavior appropriate counseling strategies and handouts. And I hope that during our introduction discussion that you've learned some new ideas and you've been reminded of some things that you already knew. If you have any questions, please do not be afraid to reach out to the Ohio AAP or myself. It's been wonderful discussing about these very important topics. All of these topics are discussed in more detail throughout the program and on our Ohio AAP website and in our handouts. Thank you. Thank you very much.